Hey guys, my name's Andrew. I'm one of the first year doctors in the Nepean Hospital. I've been asked to give a quick presentation on Paediatric Airway Obstruction. So let's get into it. So just for a quick overview, we'll look at the anatomical, physiological considerations, so kids versus adults, and then we'll kind of go through a few of the common causes of paediatric airway obstruction and kind of touch on a few of the things that might be perceived um, for paediatric airway obstruction. And then we'll finish up with a case study and kind of do a few, kind of highlight the few takeaway points from this. Okay, regarding anatomy and physiology of kids, as you'll hear lots of pediatricians say, children are not little adults, and the anatomical and physiological differences are quite important when you're thinking of airway management. So in general, just because kids are smaller, they've got narrower airways and they're much more easily obstructed by things like edema, blood, foreign bodies, and external compression. The issue with this is it's not proportional, so even mild narrowing can lead to a rapid increase in airway resistance and subsequent work that the child needs to do to maintain saturations. Um, Relative to body size, they've got much larger tongues and adenoids, so these themselves are increased risk of obstruction. Compounded by the longer floppy epiglottis, this can be quite a difficult for the anaesthetist or ED physician who's doing laryngoscopy to secure the airway. Not something we have to worry about, but something to keep in mind. With the longer epiglottis, don't be concerned if you do see it in the oral cavity or at the back of the oral cavity when you're doing a ENT examination, because this is usually normal in kids. Regarding head size, kids on average have a larger occiput compared to their body of adults. Resultingly, when you're trying to do airway maneuvers on a child, the natural position for them will be for their head to tilt forward into a flex position, resulting in upper airway obstruction. With the high anterior larynx and the more floppy upper airway as well, if you do traditional adult maneuvers with the hyperextension of the neck, you actually result in actually obstructing the airway too. So a neutral position is ideal to maintain the airway in kids. And then lastly, kids have high energy requirements. They've got increased metabolic requirements, and they've actually got reduced functional residual capacity. So pretty much kids will deteriorate quicker than adults, and that's why it's important to escalate quickly. So for the general examination of the pediatric airway, I kind of like the kind of pediatric assessment triangle approach. We do appearance, breathing and circulation. So for appearance, you look at the general appearance of the child. Most of the time you can see how they interact with the world, interact with their carer, their just general demeanour. So are they consolable from their carer? Do they have anything abnormal about them, whether their look, their gaze, their posturing? Things specific to airway obstruction would be if they're tripoding, they're sitting forward, their shoulders hunched. If they've got abnormal tone, obviously if they're hypotonic, if they've got decreased consciousness, you'd be very concerned. Regarding the work of breathing, so I kind of like the way it's kind of broken down here into sounds. So if you're thinking of sounds, you'd be thinking of stridor. So it's an inspiratory upper airway sound. They might have wheeze, which can be a whistling or a musical sound of usually associated with expiration. They can increase work of breathing, so that's where they kind of talk about retractions. So I always like to talk about from top to bottom. So increased work of breathing would be nasal flaring. You'd have grunting, which is a child just trying to maintain PEEP. You can have suprasternal, intercostal, or subcostal retractions, and then you can also have accessory muscle use. So I always kind of like to look at the abdominal muscles to see if they're trying to assist with breathing. And then lastly, look at circulation. So you look at the face, you look at the peripherally. If they're peripherally shut down, you'd be very concerned. If they've got skin color changes, so if they're pale, if they've got mottling, if they look cyanotic, you'd be very, very concerned. So I'm going to mention this a lot in this talk today, but a lot of the severity and subsequent management of children can be assessed at the end of the bed and just doing general observation. And you should always escalate early. As previously mentioned, kids could deteriorate much faster than adults. So if you're very concerned, escalate early. So initial management for a child is usually to try and be calm, observe closely, try and let the child be comfortable on the carer's lap if appropriate, and obviously you treat the cause and consider location of treatment. With airway obstruction, you'd obviously offer, or upper airway pathology, supplemental O2 has its place, but initial IV access, which is a hallmark in adult treatment, especially in the ED, is not necessarily needed straight away. Although I've crossed out lateral X-ray just really in specific to epiglottitis, just because in epiglottitis that is a medical emergency that should be clinically diagnosed, and airway treatment is the first line. It shouldn't be held up. Securing of the airway shouldn't be held up for X-ray. I do ironically mention a few X. Okay, so the first thing we'll talk about is airway foreign bodies. So according to UpToDate, airway foreign bodies account for approximately 1,000 pediatric deaths per year in America, with 80% of all unintentional deaths in children under the age of 1 year. So the peak is about the ages of 1 to 2, with 80% of airway foreign bodies happening below the age of 3. You kind of have a range of this peak of between 1 to 2 is because at this age children have a associated oral fixation. They've got increased mobility at this age with crawling and walking, and they're also kind of developing their fine motor control. This is compounded by both the immature swallow as well as incomplete molar development, so the food they're chewing is not properly chewed. In general, younger children are more likely to aspirate food versus older children who aspirate non-food objects. And then similarly, thankfully, to adults, the right bronchus is the most common place for things to lodge. Regarding history for airway foreign body, kind of depends on the age of the child, depends on the site, so the actual anatomical location of where it's settled, and it also just depends on the stage. So when I talk about stage, I talk about the timing after they've presented. So 50% of people or children with airway foreign body will be asymptomatic, although 90% of them will have some sort of history of an aspiration event or a choking episode. Now, talking about the site, if it occurs in the larynx or the main bronchus, it can be rapid with a sudden onset accompanied with vomiting or choking. And if you get a total occlusion, it can actually lead to cardiorespiratory arrest. So the history there will be one that will kind of be taken with presumption in resus. If it's below the main bronchus, it's most commonly between the ages of 6 months to 4-year-old, you similarly have an aspiration event. And then it can either present in the second or the third stage or the first stage even. So when we talk about first stage, we're talking about the actual event itself. So you get the acute coughing phase with the choking, potential of stridor and respiratory distress. Second stage is when the child's usually asymptomatic. You get the settling of the object in the location where it is, and you get an associated reduction of the respiratory reflexes to expel the object. And lastly, the tertiary phase, so the third phase, is when you present with complications of this. So you get associated infections, you can have a chronic cough, unilateral chest findings, so unilateral wheeze. You can get symptoms kind of mimicking asthma. Delay in presentation can actually result obviously in permanent damage. Things you'd be concerned about would be bronchiectasis. So for the examination of a child, you'd want to, if they're not too distressed, you'd want to look in their ear. You do an ENT examination, especially of the throat and oral cavity. Abnormal vital signs would be pretty rare, but you would still do them. Common things you'd probably see is a cough, maybe unilateral chest findings as discussed, so maybe also reduced breath sounds, maybe a prolonged expiratory phase, asymmetrical chest rise even, potential tracheal deviation, but otherwise it could just be normal. And I would say a normal exam does not rule out a convincing clinical history. So investigations you do is, if it's an opaque foreign body, you do a chest x-ray. I would probably also do an abdominal x-ray. Things you'd be looking for would be the foreign body itself, or you'd be looking for effects on the parenchyma of the lungs. So whether that be segmental or lobar collapse, or also maybe localized emphysema in expiration. So you can do a ball valve obstruction. That's if you do expiratory films as well. But good luck getting the radiographers to coordinate that with the child. So management. So if obstruction is total, that the child's going to be very, very unwell, and you're most likely going to have to commence CPR. And if it's in hospital, it's going to be a MEC call. and you'd probably progress to ALS. This is very similar to the CPR that we've all done and should renew yearly. So if in a hospital you're trying to open the airway and under direct vision with McGill's trying to remove it, otherwise you would then alternate between the 5 blows with an open hand to the interscapular area, and then 5 blows to the chest, similar to CPR, and you'd be alternating and checking if the foreign body has appeared and remove it if possible. If partial or asymptomatic, you'd probably refer to ENT or a respiratory or a pediatrician service for examination and retrieval under anesthesia. Prevention is very important in this age group, so education of the parents is pretty vital. So appropriate foods for kids at appropriate ages. So if they're less than 15 months old, they shouldn't ever be offered food such as popcorn, hard lollies, or raw carrots or apples. And then just with eating hygiene, you should always encourage good eating practice. Always encourage the child to sit quietly while eating, and then try and offer food one piece at a time. And then lastly, kind of common sense. Avoid toys with small parts for children under the age of 3.